Hello, my name is Lichaa. I'm an interventional cardiovascular specialist. Today's video focuses on a hot topic, especially in the light of major shortages of IV iodinated contrast around the world. We're going to be talking about 10 tips and tricks in adequate CO2 angiogram, whether arteriogram or venogram, with good quality images. So the first tip is make sure you have a dedicated CO2 imaging software, which is necessary especially for infrapopliteal visualization. So a dedicated DSA CO2 imaging software, most imaging companies have that. Ask your techs to try to find it or call the company. Number two, very important to be very careful about the prep. It's very easy to get an air embolism situation if you're not very careful about preparing the system very well. There are multiple systems on the market. We'll be very familiar with the technical steps. Number three, try to use small end-hole catheters. So usually 4 French end-hole catheters. Try to avoid the use of pigtail or other catheters with side holes. You can even use CO2 with 0.18 microcatheters, especially if you're taking some infrapopliteal selective images. Number 4 is to pre-treat with nitroglycerin, at least 100 micrograms selectively. Will give you a significant improvement in CO2 images, especially if the cardiac output is low. Number 5, selective imaging is very important with CO2. So getting an abdominal aortogram to look at the SFA is not the best idea. So obviously get selective into the vessel you want to image and use end-hole small catheter. And this applies specifically to the infrapopliteal vessels. Number 6, know very well that patients with limb ischemia who have poor outflow are going to have transient ischemia when you inject CO2, and that hurts quite a bit. So in cases where you think you are going to intervene on infrapopliteal vessels and diffusely diseased vasculature, it will be better to start with general anesthesia so you can have no motion and be able to get DSA images with road mapping. Number 7, it's the rate of injection that you will learn with time. It doesn't have to be too fast and it cannot be too slow where you barely can opacify the vessel. So what's an average injection rate? In the aorta, I personally, and in the inferior vena cava, I inject 20 cc's per second. In the iliac arteries, usually 15 cc's per second. When you go down to the SFA and popliteal, 10 cc's per second. And in the tibials, usually 5 to 7 cc's per second. And of course, every patient is different with your first injection, especially depending on the cardiac output of the patient. You'll be able to gauge the speed at which you're injecting CO2. Number 8 is you have to be careful about COPD patients. Obviously, you're injecting CO2, so it's going to accumulate. So have a lower threshold in COPD patients to stop injecting. And if you're working in an aorta with mesenteric ischemia, that's also another consideration. You have to limit your upper limit of CO2 volume to minimize mesenteric ischemia from the actual CO2 stagnating in areas of poor mesenteric flow. And number 9, because the CO2 has a tendency to kind of stagnate in areas of ischemia, when you're going on with the case and it's getting prolonged, make sure you move the limbs in different directions to try to dissipate any potential CO2 bubbles that are trapped in your outflow. And tip number 10 is if you're connected to the interventional sheath and you injected CO2, make sure you flush saline right after that. I personally hook up the system to a pressure line with saline flowing after I inject CO2, because even with a therapeutic ACT, you can still have thrombosis of the sheath, and this has happened in multiple instances. So be careful about remembering to flush the sheath after CO2, and don't keep CO2 in the sheath for the duration of the procedure. And these are some tips and tricks. I hope it's helpful in your daily practice. And a little plug for Sky meeting next week on May 19th to the 22nd in Atlanta, Georgia. Hope to see you all there. Thank you.